As we all know, I don't need to explain the stages of osteoarthritis, but to put it in a nutshell, it is basically the cartilage, whichever pathology of arthritis, particularly osteoarthritis, it goes into slow degradation of cartilage. So we've got stages, the left-hand corner picture that you see there, with a normal cartilage, to then it going into fibrillation and also the fissures and the thinning, and slowly total, you can say, wear or denudation of the cartilage from the bone surface, leaving exposed bone there. Now, as an orthopedic surgeon, I obviously like to do operations, and operations, we know, do a great deal of good in severe osteoarthritis. That is when arthritis has gone to the stage where there is no cartilage left in the bone and the patient is having a lot of disability. What we are talking about here is not at that stage. I mean, that is easy to imagine and a technical job. It works well. But there are other treatments which are available in the earlier stages of arthritis, and that is probably what we also need to explore. What is also important is to realize that joint replacements are surgeries which are having very good results. But on an average, if you look at Indian figures, we are on an average doing joint replacements at relatively very, very young ages. What we all need to sit and think is how we can delay the progress of that arthritis. One thing, of course, would be to detect injuries early and prevent them. But even in earlier stages, when things have not gone to that bad a stage, do we have an option of making things better for patients? Anyway, that is joint replacement, and patients with joint replacements are showing very good activity these days if done at the right time. Here you've got people who can ride scooters, can walk pretty normally at the 6-week point, and they can do other activities like kneeling and sitting cross-legged at the 6-month point. Of course, if they want to do activities which require squatting, that is also possible, because our prosthesis today and the techniques available are very good. We just need to go into how osteoarthritis develops. I don't want to bore you with long technical slides, but essentially it is a catabolic process going on. The synovial fluid is the key here, which contains glycoproteins and proteases, enzymes which cause degradation, start with acting at the matrix and the synovial fluid, causing inflammation. At a later stage, you've got catabolic processes which go over the anabolic processes, leading to destruction. Coming to treatments of arthritis, we know that there are a lot of treatments out there. Essentially, when it comes to medical managements, or medical and surgical put together, we've got the conservative managements, which is the analgesics, which are wonder drugs. Of course, we've been talking about their side effects, but they are drugs which have done well for a long time. We also now have certain disease-modifying drugs which could be equated to a bit of voodoo at the moment, because we don't have fair evidence for them. We don't know whether glucosamines or collagen supplements work 100%, but a good number of patients are experiencing good results with them, and definitely they are something which we cannot leave off our armamentarium. At the fag end, of course, we've seen surgery, but in between, what we do have is injection treatments. We may not have 100% hardcore evidence for all of these injection treatments, but they are definitely an option where there is not much of side effects or bad things to think about, and there are instances where it helps patients, particularly if carefully selected. So, talking about injection treatments, there are principally 3 different types of injections that are available to us today. And I always think of this when I put it in a nutshell. The oldest and the most tried, still the most popular out there, is steroid. It has been used for a long time and still the most popular injection used. It does help. We have been criticizing it. That is long or rather repeated injections of steroids don't really do good to joints. And we know that. Especially those among us, a few orthopedic surgeons here who do joint replacements know that a joint injected repeatedly with steroids is not very easy to replace. You get intense scarring and severe destruction in the joint. Having said that, steroids have a certain place, and in cases where there is particularly a large inflammatory component or in flare-ups of arthritis, steroids work beautifully. The second one, and we're going to talk about that in a bit more detail today, hyaluronic acid, which, as we talked, is really replacing a natural synovial fluid. Now, evidence for hyaluronic acid is still about, I would say, level 2 or level 3 at the moment, essentially restricted to few cohort studies. What we do know with comparative studies with steroid is that HA does have a bit more potent action, that is, it lasts longer than steroid, and more importantly so, it doesn't have the bad effects of steroid. So if it works, it probably is a much, much better treatment in the right indication. And there is the new kid on the block, PRP. This is coming around and a few centers in the world are trying it. There have been some trials comparing HA to PRP and of course with steroid. These trials are again not very good level randomized trials, so we can't say with 100% definitive evidence, but what we do know is that it can have a certain reparative effect on cartilage. What we also do know is, if at all, it is pretty comparable to hyaluronic acid. It does not have side effects like steroid. What we do need to know with PRP is that we have a large number of reps coming saying this PRP, that PRP. If you are giving PRP in your practice, you really need to know the content of that PRP. There are about 3 to 4 PRP preparations available in India, and all of them are not actually platelet-rich plasma. So you have to really evaluate how much of platelets are going into the preparation that you give the patient. The downside is you do get a little bit of an inflammatory reaction with PRP, and there are studies now combining PRP and HA as well to give good results. So coming back to HA, what does synovial fluid do? Synovial fluid is a wonderful physical property of viscoelasticity. That is, as the pressure in the joint increases with fast impact, the fluid actually gets thicker and it makes you absorb shock in our joints much, much better. Whether we can replace that with an artificial synovial fluid is difficult to say, but at least we do manage to reverse, or rather you can say effect some of these functions of hyaluronic acid. Precisely a little bit of shock absorption in the joint, a good amount of lubrication which can be provided with artificially created synovial fluid, and it might have some painkiller and anti-inflammatory properties as well. What we do need to know is this is artificially manufactured from natural sources. So we can't, unlike PRP, produce a synovial fluid from another part of the body and inject it into the joints. It has to be manufactured from outside, which is why it being proteinaceous in nature can give allergic reaction. What I ask my patients is, have they been to KFC before I give a hyaluronic acid? No, because most hyaluronic acid comes from chicken. So if there is severe chicken allergies or similar allergies, it's difficult to say, but I have had patients who have reacted to hyaluronic acid as well, and it is difficult to say who of them will throw a full-blown inflammatory reaction. What you do usually get is a little bit of swelling in the tissues, a little for about 2 to 3 days, which was not seen earlier when we gave steroids occasionally. Coming to the types of hyaluronic acid out there, there is not only different manufacturers, there are a whole variety of types. Hyaluronic acid has been around for at least 15-20 years, and different types of preparations are available out there. They are, you can say, basically classified on the basis of their molecular weight. And molecular weight is measured as million Daltons. So what is treated as high molecular weight is something above 6 million Daltons, and you have hyaluronic acids which are above and below 6 million Daltons. What they do say is, I mean, there is a large amount of comparative studies and this and that, which are again cohort studies, but they do say that 0.5 to 1 million Dalton would be an ideal hyaluronic acid, which will not be broken down or washed away in the joint. So what you want is an artificial material which will stay in there. There are different preparations which have different volumes, which we'll talk about when we talk about, comparing preparations. Even though we talk about high and low molecular weight, we haven't really been able to differentiate or show a very different response between the high and the low molecular weight ones. We do know that low molecular weight probably lasts longer, but at the moment, like I said, this is still a bit of level 3 or circumstantial evidence. In short, if we have to kind of compare which preparations are available to us, I think it is important for us all to go home with one small thing there. The older generation hyaluronic acids were essentially 2 milliliter injections. So they come all in disposable syringes, which are 2 ml injections. And what was started when hyaluronic acid came in first was 1 injection per week for 3 weeks. And then they said that will give you a good effect for about 6 months. That probably did work, and evidence is there. Most of the evidence is with these hyaluronic acids. However, what we have to kind of compare this to is how things were in the older generation. Because we don't really, even though it is an injection and it is an easy procedure, any injection into a joint can anytime be hazardous and can give rise to severe infections. So you have to worry about giving intra-articular injections in small clinics, which is why you have to look at this with a pinch of salt. So when I think about older generation and 3-stage HA treatment, I talk about effect being given in slight stages. Little parts being shown and the full effect in the 3rd stage, perhaps. Whereas with the newer generation HAs, everything is at 1 stage. So you have 1 large injection. With 1 injection, you're supposed, and they have shown that it lasts in the joint for at least 3 months. And pretty much like the modern movies, 1 dose, the full effect. When it comes to newer injections and talking about different injection treatments, the same note of caution again, giving an injection in a joint can be a hazardous procedure, and we have seen septic arthritis caused by these injections. So one really has to be careful. It has to be maintained under very, very good aseptic precautions. It can, of course, be given in a clinic environment, but it has to be a clean environment. Definitely not that sort of picture with the shoes and full-sleeved surgeon giving the injection right there. Again, when HA is given, bear in mind that you can have the occasional patient who can throw an allergic reaction. So ideally, it should be where you have your access to resus equipment, at least if you need. It is not that bad, but you don't want the 1 in a million one where things go from bad to worse with a single injection. Coming to comparative brands, there is a good variety of brands out there, and Cadila has introduced this last one called Halonix 1. We've known about the earlier brands which have been there for ages. There is brands like Durolane and Synvisc 1, which have been around for a long time. Some of them are larger volume, which is 6 ml, which are showing longer effects and good effects. One comes in combination with a bonding, which they say will make it last in the joint for longer. Of course, there are going to be financial differences among each of them. There, I would say, compared to just to evaluate it from whatever, because all that, even the financial aspect is very important for us. To compare Durolane Synvisc 1 with Halonix 1, Halonix 1 is available at a cheaper price because it is made locally. It is not as scientifically evaluated with studies as Durolane and Synvisc 1, but that is what we as potential users should probably engage in asking the pharmaceutical to do a study. So, and we could be taking part or involving our patients in the study, so we have our own data with it. Definitely being manufactured locally reduces the chain of things. For example, something like Durolane, which is manufactured abroad and marketed in India, only has more people in the chain for profits, which is why the price increases, not necessarily because it is a better drug at the end of the day. So molecular weight, we talked about again. This one, they say, has a molecular weight of 0.5 to 1 million Daltons, which is probably more like the normal synovial fluid and probably will help last in the joint longer. At the end of the day, what we want for our patients is ridding them of disability. And this should be our aim. It is not only about treating it with a particular drug. There isn't a magic drug out there. There isn't a magic surgery out there. There isn't a magic injection out there. What we have to be able to do is do the right thing for the right patient, and for that patient, what disability they have, evaluating that and giving them the right treatment for that. It is not that for everybody joint replacement is going to work, and it is not that for everybody an injection is going to work. What we had done to celebrate World Arthritis Day in Mangalore last Sunday was, we had a group of our patients who've been treated over the last year with various treatments. There are some of them the younger ones, who have had disease-modifying treatment for rheumatoid arthritis. There's some of them who've had HA with keyhole surgery to, for early lesions, so as to prevent them getting further arthritis. And of course, the older ones in that lot mostly have had joint replacement. What we wanted to do is just get these patients integrated into normal society. So whatever treatment, our aim is that patients with arthritis can actually have a normal life. And normal life actually means being able to integrate into what all of us do. Just because they have a joint replacement or they are old and arthritic doesn't mean they should be sitting at home. We can give them an entirely good quality of life with whatever treatments. And that's what we should aspire for. Thank you.